All right, next I'd like you to talk about medical issues. So you could list them and then give us like one or two sentences on diagnosing it and clinical diagnosis, and then one or two sentences on management. So we'll sort of do like a lightning round on the medical thing, because we're going to come back and talk about this a little more in a week or two, hopefully.
Okay, yeah, that sounds great. So as far as medical issues, we'll start with one of the most common ones I see is heat illness and heat stroke. And I'm going to specifically talk about heat stroke briefly because that's the most emergent diagnosis of heat illness on that spectrum. So heat stroke is a core temperature greater than 104 Fahrenheit and mental status changes, which can be anything from minor confusion to ataxia to complete loss of consciousness. And the most critical thing with heat stroke, I know you've had a podcast on this previously, so I'm not going to rehash everything, but getting that individual into definitive cooling, which ideally gold standard is cold water immersion within 30 minutes. That golden half-hour rule is really critical. And multiple studies from the Marine Corps recruiting depot out in South Carolina, as well as the Falmouth Road Race, has shown zero mortality with appropriate treatment, getting that core temperature down to 102 or less within 30 minutes. I know that, so the gold standard is really the cold water immersion. Another option, if you don't have a cold water tub available, is dousing in ice water, putting ice towels all over the entire body. Really, the ideal thing is you want to cover the entire body with some kind of ice or cool, cold packs as much as possible, because placing ice packs just in the groin and the artery over the arteries isn't typically enough to get them down within that 30 minutes.
Okay.
So covering as much as possible.
If they stay over 104 degrees for more than 30 minutes, what's the mortality rate, the death rate, roughly? Do you know?
It can be pretty high. To be honest, I don't have the number on me, but typically,
but it's real. People die.
At least renal and hepatic failure requiring ICU level care.
Okay. All right. What else you got? Medical issues.
So other medical issues. So this one is important, hyponatremia, exercise-associated hyponatremia, because the symptoms can often overlap with heat stroke. So you'll have someone who is, they just completed a really high level of exertion. They present, they're confused, altered gait, mental status changes. And you always have to keep in the back of your mind when you're examining them. If they have a normal temperature and you're not sure what's going on, consider exertional hyponatremia. Because this is very commonly seen in high endurance events, especially those over 4 hours, which is really a lot of what we're doing, especially here in the pipeline. And really there's two categories of exertional hyponatremia. So they're either going to be drinking too much and hypervolemic, that they're essentially diluting the sodium.
Too much water without electrolytes. Okay.
Exactly. That's the most common thing seen in the civilian world. So most endurance athletes are having this hypervolemic, too much water drinking, causing their hyponatremia. Another type that's seen is hypovolemic. So you're just having such significant fluid and sodium loss in your sweat and not repleting that appropriately. You can develop hyponatremia from that. That one we see often in the military because it's usually very high levels of exertion, but it's not seen as much on the outside. But again, symptoms can vary from altered mental status, confusion, vomiting. Eventually they can develop seizures from the cerebral edema, and then eventually death. So the biggest thing, since I know, PJs don't carry iStats, because ideally you could check their sodium level and make that diagnosis, but really just having an awareness that that could be what's going on when you have a patient who's very confused and altered after a high level of exertion, and getting them to that higher level of care. In the meantime, you can actually treat, assuming that they treat empirically, assuming that they have hyponatremia. If it's mild, you can give them some IV fluids, which you'd likely, IV normal saline, which you'd likely be doing anyways. With, a little bit out of it, they seem dehydrated. And then if it's real severe to the level of their seizing, you definitely want to give hypertonic saline, So you can give 3%, 100 cc's push. If they start to improve, go ahead, you can give a second one. And that's really the best treatment for acute hyponatremia that needs to be corrected right away. But typically for mild, which is usually what we see here in the pipeline, start with oral fluids if they can tolerate it. So oral rehydration salts, drip drop, sodium tabs, things like that. If they can't tolerate PO, then that's when you can give a bolus of normal saline. If they improve, you can continue giving normal saline, because normal saline is hypertonic to the body. So 154 milliequivalents per liter compared to our normal body, 135 to 145. So it is safe to give normal saline in mild cases.
So I think one of the other foot stomps we want to give you is, if you're performing for distance and time and exertion in hot weather or warm weather, is to really try and maintain your electrolytes, either with some sort of electrolyte mix, drip drop, scratch, Gatorade, whatever, almost doesn't matter, you know, go to taste. Or some of the sports foods, whether they're bars or goos, have a fair amount of sodium and potassium in them. The bottom line is, do not, you know, go more than an hour or so of just having plain water. You know, I don't know what the number is, 1 hour, 2 hours, but at some point you need to be replenishing, you know, maybe not just your sugar, but also the sodium and potassium. So I think the big thing is don't drink water only without ingesting food or some sort of electrolyte mix as your only fluid or intake. That's where you run the risk. Agree?
Yes, definitely. And we also work with excellent dietitians here who can do sodium sweat content testing. And so that can be very helpful, because it's hard to give specific recommendations. Everyone's different. So, you know, consulting your dietitian, get that sweat testing done, and get some good recommendations as far as how much fluid versus electrolyte consumption you need.
So ideally, when we deploy to the hot environments, should we be with the ideal thing, like do all professional athletes get that done who train and work in warm weather, or is it just people who develop problems and they got to get evaluated? What should be the standard?
And typically with professional athletes, that service is available. Here in the military, at least within our unit, we do have a dietitian team, but we don't standard test everyone. So it's either those individuals who already know ahead of time, hey, I have a history of dehydration or heat issues or hyponatremia, so I'm going to get tested and get evaluated. Or when we do have cases of hyponatremia, I will send them to the dietitian.
Okay. All right. What else can we talk about medical?
So I want to hit on exertional rhabdomyolysis as well. That's very common. We'll just talk about that briefly. So typically, it's very, very common in our pipeline, typically presents with muscle pain, severe muscle pain, and can present with dark urine as well. That muscle pain can progress to significant swelling and compartment syndrome. Lab diagnosis is CK level greater than 5 times the upper limit of normal, which is about 200 is the upper limit of normal. But it is important to know, especially in our population, that it can be normal for athletes and military members to have a CK that is 5,000 with really extreme workouts, but as long as you don't have that kidney injury and hemoglobin in the urine, hemoglobin or myoglobin, it's not necessarily rhabdo. So you need to see those kind of end organ damage findings, typically renal kidney injury, blood in the urine, and hepatic injury to really diagnose rhabdo. The treatment is IV fluids. So you want to give about 1 liter every 6 hours IV. Your urine output goal is about 200 milliliters per hour. So if this is something that if you're suspecting rhabdo, it's good to get them to a higher level of care. If not, encourage PO hydration as much as possible and monitor urine output.
What are some tips you'd have for clinical suspicion of rhabdo versus just somebody sore from their training? What should they be looking for?
The biggest thing is going to be the urine. So if they're not urinating at all, they likely have some kind of kidney injury, or if they have very dark red urine, I definitely want to get them to a higher level of care.
Okay, cool. And is the muscle pain they have, is it obviously more than the usual soreness from hard training, or is that easy to confuse and that's not a good thing?
It typically is a little bit more, and I often see it in the lower extremities, and the back are very common. They'll have really severe back pain, quad pain. Those are kind of the most common. It really can be anywhere though. So just routine follow-ups, ensuring that they're not developing edema and compartment syndrome. Just keeping a close eye on them is going to be important.
Okay. And then just to fill out the medical issues, I have one more question. What's the chance of people just getting dehydrated and actually hurting their kidneys from just being dehydrated? How often do you see severe dehydration, and how often can that be associated with a kidney injury?
We see that very commonly in our training. I don't have any numbers offhand, but if any trainee, our threshold for sending a trainee to the ER for analysis would be they're no longer PO tolerant, they're vomiting, they're having diarrhea. At that point, once they're behind on their fluids, they're on their way to kidney injury, and they're unlikely to be successful in continuing the pipeline. So my threshold is really either lack of urination or PO intolerance.
So is that idiosyncratic, or is that people being knuckleheads and not drinking?
It kind of depends on the time of year. Here in San Antonio, staying on top of hydration can be very difficult. So we see a significant amount of kidney injury during the summertime. There's always at least 5 or 6 in each selection course that end up having to go to the hospital for IV fluids. It's just something that we see commonly, but fortunately we recognize it very quickly, and they typically are only in the hospital for a day or two.
Okay. I think that takes us through medical stuff. Now let's get to everybody's favorite topic, and that's what the heck happens to people in the pool topic.
Yeah, so I can talk a little bit about a couple topics. So one thing that we see very commonly is hypoxic events or hypoxic loss of consciousness, previously referred to as shallow water blackouts. This occurs very commonly in our selection courses and really throughout the pipeline. We actually have had 108 cases since January of 2021. The vast majority of them, fortunately, resolve very quickly. So the way they typically present is, during an underwater iteration, they will completely lose consciousness. They don't aspirate, they don't try to breathe, they just completely lose consciousness underwater. Our safety swimmers pull them out immediately. And then as we get them out, we're doing sternal rubs, waking them up. Usually they start breathing on their own as soon as they're out and have a rapid recovery. Typically, they don't even require oxygen. Their SATs will recover very quickly once they start breathing on their own. But sometimes they will require oxygen. Sometimes they'll require airway placement. Typically, like NPA is enough to get them awake and breathing again. We always have at least 2 to 3 paramedics on the deck, as well as a specially trained athletic trainer, and then a physician as well to help manage these. And then we have a large number of rescue swimmers, because honestly, getting them out of the pool quickly is the critical part of their fast recovery. So having those safety swimmers that are very experienced and able to recognize these events quickly is the real critical part to save them. The thing that causes hypoxic events is, the loss of consciousness is from hypoxia, reaching that critical level where their brain basically just shuts off. But typically the reason that happens is because their CO2 level threshold doesn't get high enough that they feel the need to breathe. So oftentimes with hyperventilation, whether or not it's intentional, they're working out hard, they're hyperventilating, breathing fast, they're blowing off their CO2, and it's actually the CO2 level rising that's the threshold to breathe rather than the oxygen level. And so when they're underwater and their CO2 level starts lower because they've hyperventilated, they've blown off a lot of their CO2, it takes longer for that CO2 level to rise to a critical threshold to tell their brain to breathe. And if their oxygen level drops to that threshold of losing consciousness before the CO2 level hits the drive to breathe threshold, then that's when they'll go out. And oftentimes they don't even know that it's coming. So that's usually I will teach them to avoid hyperventilation, avoid blowing off their CO2, and trying to slow their breathing as much as possible.
That was probably the best explanation I've ever heard of that. That was great. I appreciate that.
Yeah.
How often do you have to do any, assisted breathing with a bag or do something more dramatic? Is that rare or once in a while?
It's pretty rare. We've had one case of an individual needing rescue breath before kind of waking up and coming to, who was pretty hypoxic. But for the most part, doing that sternal rub, a good jaw thrust, and sometimes an NPA placement, that's enough to wake them up and get them breathing on their own.
Cool.
Fortunately.
Awesome. And then what are a couple other things you see in the pool?
Yeah, so another big thing that we see is swimming-induced pulmonary edema, or SIPE. And so this is typically presents as shortness of breath and hemoptysis, or frothy sputum. And then we often will see hypoxia at the same time. So this has been described mostly in divers and is associated with water immersion. It was first described in the 1980s in scuba divers and triathletes and the military combat divers. It's previously been described mostly in like cold water and open water. However, we obviously see a lot of cases within our training pipeline in the pool. So the incidence rates in the literature range everywhere from 1% to 60%. Oftentimes it's unreported or underreported because SIPE by definition typically self-resolves within 48 hours of removal from the water. And so a lot of times the trainees will remove themselves from the water, and if they don't have any more training iterations that day, it will self-improve, and then we may or may not catch that or know about it. So it's likely underreported. But sometimes it is severe enough to cause significant pulmonary edema that requires oxygen, positive pressure ventilation, and hospitalization for supportive care. The thing that causes SIPE is essentially a central redistribution of blood volume with increased venous return, which results in increased cardiac preload, increased left atrial pressure, and then in conjunction with exercise, you have a higher cardiac output. So this all results in increased pulmonary artery pressures. And then you have this hydrostatic pressure that is causing alveolar edema, and it can also cause a breakdown of the capillary alveolar border, which is what results in the hemoptysis that we often see. So I've seen a handful of these by the pool. One we had recently actually did not have a hypoxic event, no loss of consciousness. He removed himself from the pool saying he couldn't breathe, short of breath. He was coughing, had some red clots that he was coughing up. He was hypoxic. His oxygen level was in the upper 80s on room air. So we immediately placed him on a non-rebreather, 15 liters. And he was actually coughing into the non-rebreather to the point that we were seeing blood clots in the non-rebreather bag. So he was transported to the hospital and found to have mild pulmonary edema on chest x-ray. Did well with supportive care and recovered within 24 hours. But it's something that we do commonly see, and it's important to recognize it because it will continue to progress if they stay in the water.
Cool. Can you just say again what SIPE stands for?
So it's swimming-induced pulmonary edema.
Swimming-induced pulmonary edema. And then I just want to translate for the paramedics that for some reason, a lot of the blood is shunted to the center of the body and essentially increases the pressure, the blood pressure in the arteries of the lungs, which leads to leakage and ultimately the membranes that separate the vascular system and the alveoli or the air sacs break down, so they actually bleed into the lungs. So there's a combination of leaking of fluid from the increased pressure in the vessels. And then also there's a breakdown of the membrane, so they start to bleed besides just getting the free water, so to speak. Is that a good summary for the paramedics?
Yes, yeah, exactly. That's
Cool.
how it works.
Okay. Obviously, I'm doing that for myself, learning this, but I do it under the guise of saying, hey, I want to make sure the PJs understand. Anything else that you see in the pool? Other injuries or?
Yeah, the other common things that we see sometimes are barotrauma. So that can range from a TM perforation to sinus barotrauma, especially if they have a sinus infection. So being able to quickly recognize and treat individuals with sinus congestion with Afrin before they go in the pool is important to prevent that barotrauma if they're, if they must continue to train. If it's significant enough, we'll often remove them from pool training because a TM perforation is pretty significant as far as, it's a disqualifying condition, requires a waiver and a time period of 3 months before they could potentially return to training. So prevention is key in that one.
Okay. And then the sinus barotrauma, do they just get blood coming out of their nose? How do you pain? How do you diagnose it?
Yeah, we see that pretty commonly. And so using Afrin, again, is going to be critical. And then just any kind of sinus decongestant, Sudafed or Mucinex with frequent observation and reexamination of their tympanic membranes to ensure they don't have a rupture.
Okay. And then if they come out of the pool and they got blood coming out of their nose, do you get an ENT consult or you just manage them conservatively typically?
Typically I do really well with Afrin and then gauze, like just providing that tamponade to prevent the bleeding from progressing. Fortunately, we've had them do well with that by the pool. We're able to get them back in training.
Cool. So we talked about skin issues, musculoskeletal, medical issues, and pool issues. Does that cover the bulk of sort of what you see?
Yes, yeah, that's the majority of what we see. Of course, we still see the occasional virus, common colds, a lot of gastrointestinal distress, depending on the course. Once one virus gets into the course, they're all training very closely together. It's likely to spread, but we do our best to mitigate that and remove the affected individuals.
And my last question for you is like with regard to actually 2 last questions. With regard to the overuse injuries, do you wind up doing any injections or do you try to avoid any kind of treatment like that and let them either get through the pipeline or ANS or not get through? What's your
approach? That's a great question. I do a lot of injections throughout the pipeline. If they're specifically within the selection course, I've done that before to kind of help get them through. For example, I see a lot of like distal IT band pain causing real severe lateral ankle pain. Lateral knee pain that I can safely do a corticosteroid injection to really improve their pain. However, that does increase the risk of infection, especially with the field conditions. So it's just, you have to really weigh the pros and cons and in determining whether that's the right treatment course for them. But I am able to do that if they need it.
Cool. And my last question is related to overtraining. Do you have any sense, especially with some physiologic monitoring these days and things like that, if we lose a fair amount of people just because they can't tolerate the workload and they actually get into an overtrained condition, which I'd love to talk about on a separate podcast, all that science, versus, psychological and injury. What's your sense of overtraining being something that people can't recover from and they wind up dropping out? They just really weren't physically prepared and they've overcooked their bodies. They actually have the will to go forward, even though depressed mood and motivation is part of that. What's your sense of overtraining as sort of a physiologic kind of thing and that role in people dropping out? What do you think? Do you have any thoughts about that? And again, we haven't discussed this, so.
Yeah, we do see both like overtraining syndrome and kind of chronic injuries, oftentimes resulting in eventual removal from the course. We see recurrent heat injuries, heat illness, recurrent dehydration. And, we essentially, our job is to do a very thorough evaluation, whether it's cardiac evaluation, pulmonary. Really, with overtraining syndrome, you have to rule out some underlying pathology and do good metabolic, cardiac, and pulmonary workup. And then if that's normal, we do our best to encourage them to continue training if they're able to. But sometimes it does reach a level where we have to tell them, hey, your body's just not ready for this right now. It may be best to take a couple years, train up, get stronger, and then come back to the pipeline. And that's unfortunately very common, but we found that actually older candidates typically are more successful in getting through selection in the pipeline. So having that time to recover and get stronger and life experience as well, and just mental fortitude really helps them get through safely and successfully.
Do you have any sense of a non-scientific guess that the older people take the preparation more seriously and, aren't taking chances with their bodies, so they increase their strength and endurance and power and all those things as a part of maturity, or or it's another factor? Any thoughts?
Yeah, it's probably just a lot of it's a level of maturity and life experience, and more experience in having previous injuries and understanding your body and knowing your limits and preventing injury. Maybe they've seen a physical therapist in the past in their sports career, and they know how to stay on top of their rehab and prevent an injury from getting worse. That's something that we commonly see results in success in the pipeline.
Yeah, I would throw in as a total random guess that older people might be more deliberate about pacing themselves and not blowing up on the first event, and just totally going 110% all the time, trying to, measure their efforts. But that's a random comment, quite
Yeah,
frankly.
I would agree.
Cool. All right. Well, this was awesome. I actually learned a lot. I'm sorry to say I hadn't learned a lot of this before. And I'd love to come back at later dates and do a little bit deeper dives into things like rhabdo and dehydration from the medical perspective. We've had a great discussion physiologically about dehydration with Alan Lim and the issues of electrolyte replacement. But I'd like to talk more about the medical aspects. And then hopefully in a week or two, we'll come back and talk about a case report that you were involved with regarding heat illness and actually sort of like a multiple casualty scenario. So we look forward to bringing you back on. And I want everybody in the career field to know who Doc Hintz is, and a great asset. And we appreciate your time. Thanks so much.
Thank you, sir. I appreciate it. I enjoyed this.
Okay, everybody be safe.
Take care.